Hi, folks. So, this session is all about sepsis in the pregnant patient, or maternal sepsis. So, why do we care specifically about sepsis in pregnancy? I mean, we can already treat sepsis in the adult and pediatric populations. We have tools for the identification and management of sepsis. So, why do we care particularly about pregnant patients? Well, I can tell you for a start, it's not all about litigation. In fact, there are loads of studies now that would suggest that pregnant patients are not only at higher risk of developing sepsis, but there is a much higher risk of morbidity and mortality and just generally poor outcomes when it comes to patients who develop sepsis while they're pregnant. So we'll dive a little bit into that. And we'll talk about how we can mitigate those increased risk factors with good identification and aggressive management and treatment in the pre-hospital environment. So, sepsis in pregnancy. There are a lot of factors to this, and honestly, it all kind of stems originally all the way back to 2007 when there was this inquiry into maternal deaths. Now, that found that there was pretty much a dearth of guidance or education specifically looking at sepsis in pregnancy. And obviously that was a bit of a problem because there was this mortality issue. Now, if you look as far back as sort of 1950, sepsis in pregnancy has been studied somewhat spuriously, but over the last 10 to 20 years, there has definitely been a drive in the obstetrics community and in the midwifery community to look at this because do you know what? It's not that common a presentation. But within that presentation subgroup, the mortality is quite high. And certainly looking at meta-analyses over the last decade, a lot of those papers would put mortality somewhere around the 8% mark. So that's of the patients that develop sepsis in pregnancy, around 8% of those patients die as a result. And that's a significant number. Yes, it's less than 10%, but actually you're talking in the UK something about 15 to 20 deaths per year. And I guess the underline to that is that these are preventable deaths, or the majority of them are preventable. And again, the basis of evidence for that appears to be that in the case reports and in these meta-analyses, many cases of morbidity, poor outcome mortality has been identified as having some sort of substandard care as a factor within that particular episode. Now, when I say substandard care, and again, this is a generalization, but it appears that substandard care, rather than being, sort of poor treatment choice or poor sort of movement to a tertiary facility, it's all been about recognition, initial recognition of sepsis and or UTI, because that's generally in the pregnant population a sort of main source of septicemia. So this poor recognition of sepsis, I mean, why are we struggling to recognize sepsis in the pregnant patient? Surely one would hope that our index of suspicion is already higher when it comes to the unwell pregnant patient. But we know that there's a huge amount of physiological process that is involved in the immune system. We have our innate immune system, we have our adaptive immune system, we have these positive and negative feedback loops. And we know that when these are interrupted, or when the communication between the two becomes uncontrolled, we get this widespread tissue injury that leads to the organ dysfunction that we see in systemic inflammatory response syndrome. Now, looking at this is all about breach of the tissue epithelium, that mucosal barrier, by pathogens, and this induces the release of these danger signals, the pathogen-associated molecular patterns, or PAMPs, and these come from our monocytes and our neutrophils of the innate immune system, because the pathogens are identified for clearance by those cells. Now, I don't want to break this down in too much detail. It's a particularly good diagram when it comes to thinking about the innate and adaptive immune system and how that potentially activates our complement system. You get this over-recruitment of the coagulation cascade, and then, by virtue of that, we can see things like disseminated intravascular coagulation. It is a good diagram, but I don't want to overcomplicate the issue, because do you know what? We can break this down into a really fundamental factor here. We know that pathogens, whether they're bacteria, whether they're viruses, fungi, whatever the pathogen is, causes activation of these immune responses, which have these autoregulatory systems. The pro-inflammatory mediators, the anti-inflammatory mediators work together to allow clearance of pathogens, but prevent cell damage. However, when that immune response is overwhelmed, the anti-inflammatory mediators aren't produced as well, and it causes tissue damage. And that breakdown of tissue will eventually cause organ dysfunction. That's kind of the whole thing. And we can talk about it specifically. We certainly do talk about it specifically when we talk about immunology. But for the purposes of this, we know that it's all about tissue damage, yeah? And that's kind of the key thing about this. It's all about tissue damage. So what is going to put pregnant patients more at risk? Well, do you know what? Some kind of interference with this immune system is certainly going to have an effect on that. But we can talk about risk factors specifically for patients who are pregnant, because do you know what? These pregnant patients, potentially some pregnant patients, are going to be more at risk of developing sepsis than others. So what patients would those be? Well, things like obesity, impaired glucose tolerance or diabetes, that lack of ATP or lack of metabolism of ATP, metabolism of glucose into ATP. If that's impaired, or there's a relative lack of insulin due to diabetes and then glucose can't enter the cells, that's going to have an effect on metabolism and on immunity. If we have a specific immune problem or the patient is on immunosuppressants, then that's obviously going to contribute as well. Patients who are anemic, have vaginal discharge, pelvic infection, particularly a history of group B strep infections, not necessarily just pelvic, things like abscesses or respiratory infections. These are quite important in terms of risk factors for developing sepsis in pregnancy. Patients who have had an amnio or other invasive procedures like chorionic villi sampling, these patients might also be at increased risk because of introduction of foreign bodies into body compartments when they're not normally. Sarclage is that stitch that gets put in the cervix if a midwife might think that there's a increased risk of spontaneous rupture. That is another foreign body, so that's another increased risk factor. And prolonged spontaneous rupture of membranes, those patients that are potentially days or weeks away from delivering and have ruptured their membranes, they are definitely at higher risk as well. So we know that there are a lot of physiological adaptations to pregnancy, and we're not going to talk about them all specifically, but we need to think about them in the context of sepsis. So the pregnant patient sees these cardiovascular, respiratory, renal, and coagulation adaptations that, if you add sepsis into the mix, causes these cumulative effects. So the potentially very sick patient, the patient who is pregnant and has developed this overwhelming infection, is going to have rapid hemodynamic collapse. And that's because of the combination of drop of systemic vascular resistance because of this release of cytotoxin and the overwhelming immune response that comes with infection. You might see some increase in susceptibility to pulmonary edema, and this is because of an increase in microvascular pressure and permeability and the decrease of plasma colloid pressure. And we'll talk a little bit about that when we come on to the treatment of the pregnant sepsis patient. You may see an AKI because of increased renal plasma flow, but renal ischemia and vasoconstriction because of that overwhelming production of nitric oxide, and some cytokine-mediated renal cell injury. And this is all about chemotaxis. You may see in the very, very sick patient the increased microvascular thrombus formation, and pregnant patients are at higher risk of developing DIC as a virtue of this procoagulant and anticoagulant effect, along with the increased production of thrombin and a decrease of protein C fibrinolysis. So there's a lot of factors here that contribute to the pregnant septic patient becoming quite a complicated patient with lots of risk factors, lots of pathophysiological processes that contribute to pregnant sepsis in pregnancy being something that we don't really want to have anything to do with. But in the paramedic wheelhouse, we only really need to think about how we can identify sepsis. And these patients are going to present really differently, all the way from particularly the primary care patient who is starting to develop an infection, which might develop to sepsis. And these are the sort of risky patients that we need to kind of direct to tertiary care fairly quickly. And then we have the critically ill patient, which will obviously require aggressive management. So what I want you to take away from this really short presentation is that as paramedics, we need to adopt a really high index of suspicion for these patients, the patients who are pregnant, who have some sort of infective locus, some sort of infection going on that we can maybe do something about, or maybe direct them to the right venue of care where something can be done. I want you to ask specifically in your pregnant patients about a few things that will inform your management when it comes to sepsis, okay? And they're fairly obvious. Things like, is there any history of fever, rigors, diarrhea or vomiting, rash, pelvic pain or abdominal pain, vaginal discharge, particularly smelly or bloody discharge, productive coughs, or UTI symptoms. Now, some of these are really common in pregnancy, especially UTI or discharge or abdominal pain. These are all quite common, and that's why we need to have this high index of suspicion. We need to look at all of these things along with a combined clinical picture to make a diagnosis, or to certainly direct patients to the right venue of care. Now, the critically ill sepsis patient is going to require a very different management to the primary care patient. Now, again, not a huge amount of difference or changes to management when it comes to this, but I want you to think about being quite aggressive with it, okay? And we're quite aggressive with sepsis patients as it is, but I want you to think about high levels of O2, IV fluids if appropriate, and use GR Calc to be guided by this. But IV fluids are a good idea in a sepsis patient because there is going to be some degree of hypotension, and that could potentially be helped or corrected with a bit of volume. But that's all judicious use of IV fluid therapy. And then rapid transport to hospital with a pre-alert. And this is for the critically ill patients, okay? Now, the Royal College of Gynecologists recommended in 2019 20 milliliters per kilogram for an initial fluid resuscitation rate. I'm recommending that you be guided by GR Calc for this. There is an increased risk of pulmonary edema in pregnant patients because of this decreased colloid oncotic pressure. However, crystalloid still remains the choice for these patients, the fluid of choice, but just be judicious, 250 ml boluses as appropriate, and kind of titrate to effect as best as you can. The guidance on administration of parenteral antibiotics, Ben-Pen or cefataxime, still applies to pregnant patients. There's no specific reason why pregnant patients shouldn't have antibiotic therapy initiated pre-hospital. Now, if you read the Royal College of Gynecologists Green Top Guideline, they talk about identification of bacterial locus before administration of empiric antibiotics, but this doesn't rule out your administration of antibiotics pre-hospital. And actually, again, there's a lot of fairly good studies that would suggest that earlier administration of broad-spectrum antibiotics is going to positively affect patients. So don't be put off by this, okay? Make sure that you do your usual administration checks and check for allergies, and then feel free to administer them to the patients that are indicated, patients with purpuric rash or patients with obvious signs of meningococcal septicemia. Now, GR Calc doesn't really specifically address this. Page 328 does have a section on sepsis, section 8, and it just kind of really echoes what this presentation is all about. Think about high index of suspicion for these patients. Patients who might be at risk of sepsis are those that have diabetes, those that have impaired immune systems. It's all very much in a similar vein to what we've discussed already. So the main take home from this presentation is that sepsis in maternity is really under-recognized, and if we fail to recognize it, patients aren't going to do well. So it's all about nuanced clinical care to identify, especially in the early stages of disease. If we think about how we might identify these patients early on, then we're going to avoid morbidity and mortality down the line. Now, we know that, and this applies to the majority of pre-hospital care presentations, that there's a total spectrum of presentations. These patients we may encounter in the pre-hospital care environment acutely unwell, or as the well primary care patient that has a small infection that's going to get worse and worse if they're not sent to the right care provider. And that's what I want you to take away from this, that patients who are pregnant are at increased risk of sepsis by a variety of factors, and we need to be really sensitive to it. I wish that there was a really useful tool that we could use to really track down pregnant sepsis patients, but unfortunately there isn't. A lot of maternal units will use like a modified early warning score, or they'll use an alternative like a SOFA score that's modified for pregnant patients, but they aren't really validated in the pre-hospital arena and they're not particularly useful. It's just about you thinking about using your clinical gestalt along with your observations and your knowledge of maternal sepsis, the risk factors, the contributing factors, the physiological adaptations that should hopefully allow you to recognize sepsis early. Thanks very much.